Ascites and SBP from Schiff. Once a patient with cirrhosis liver has decompensation, the mortality is 50% in 2 years. The term ascites is derived from ascos, which means sac. If shifting dullness is present, there is a minimum 1500 ml of fluid. If there is no flank dullness, don't go ahead and check for shifting dullness. The differential diagnosis for dullness include a thick panniculus, ovarian mass, and gaseous distension of the bowel. An ultrasound can detect up to 100 ml of fluid. The causes of ascites include CLD, 85%, CCF, 3%, malignancy, 2.5%, TB, less than 1%, pancreatic, less than 1%, myxedema, less than 1%. Pancreatic ascites is due to pancreatic duct rupture or leakage from a pseudocyst. This can get secondarily infected, causing increased mortality. In sexually active women with fever and neutrocytic ascites, we think of chlamydia peritonitis. In Fitzhugh-Curtis syndrome, the treatment is doxycycline. In biliary ascites, it's because of a ruptured gallbladder or bile duct injury, and you find very thick green bile coming out of the fluid, bile in the fluid. Ascites in myxedema is due to cardiac ascites. Usually, Meek syndrome is when there is ascites plus a pleural effusion in a benign ovarian tumor, and this is rare. Pathogenesis in cirrhosis: intrahepatic portal hypertension, increased sinusoidal pressure. There is peripheral arterial vasodilatation as well. In compensated cirrhosis, there is a suppression of renin-aldosterone vasopressin, but in decompensated cirrhosis, there is vasodilatation which worsens renal function, and there is increased sodium retentive hormones like these renin, aldosterone, vasopressin, and that is what causes ascites. Patients with prehepatic portal hypertension, like in portal vein thrombosis, rarely develop ascites, and if they do, it's due to fluid resuscitation after a GI bleed. We always look for a reason for the decompensation. Is it alcohol? Is it an SBP? Is it a malignancy? Malignancy-related ascites usually has pain, but there is no pain in cirrhosis-related ascites unless there is an SBP also present. Ascites due to alcoholic hepatitis also causes pain. 50% of patients with TB peritonitis also have underlying CLD. Ascites and anasarca in the background of diabetes, we suspect nephrotic ascites or cardiac ascites. Distended flank veins indicate an IVC obstruction. This is either due to fibrous caval web or a malignant obstruction. Then we search for nodules in the umbilicus. A Sister Mary Joseph nodule suggests peritoneal carcinomatosis, is usually from the stomach. We quantify the ascites. 1+ is detectable only by careful examination. 2+ is easily detected, but there is less volume. 3+ is obvious ascites, but it's not tense. And 4+ is tense ascites. A patient who develops acute onset ascites, though its small volume, can cause tense ascites and significant pain and discomfort. Diagnostic paracentesis. This is done in all new onset ascites and if there is a sign of any infection of ascites. The abdominal wall is thinner in the left lower quadrant. We insert a needle 3 cm cephalad and 3 cm medial to the ASIS. And you always go far from scars. You use a 22 gauge needle for the diagnostic and 16 to 18 gauge needle in a therapeutic tab. We can use a spinal needle 3.5 inch thick long if there is a thick wall. Steel needles are preferred to plastic needles so that there is no breakage. Metal needles, they do not puncture the bowel unless there is a scar present. And you can leave it in the abdomen for many minutes. But a plastic needle kinks and there is also a possibility the sheath shearing off into the peritoneal cavity. We do the Z-track technique in which you minimize leakage. So with the left hand, you move the skin 2 centimeters caudal. With the right hand, you insert the needle. And you do not release the skin until the fluid enters the needle. Bloody ascites. If there is bloody ascites, you determine is it homogeneous or is it heterogeneous. Heterogeneous means there is blood along with clots. This is usually seen in a traumatic tap. But if the blood does not clot, it's homogeneous. Then it can be seen in severe portal hypertension because of rupture of the high pressure lymphatics. More than 50% HCC have bloody ascites. 10% with peritoneal carcinomatosis have bloody ascites, and less than 5% TB patients have bloody ascites. If there is hemorrhagic ascites, we have to subtract 1 pmn per 250 red cells. Chylous ascites. The ascites is milky. This is seen when the triglycerides are more than 200 milligrams percent. It forms a lipid layer. That means it layers out if it's left in the fridge for over 48 to 72 hours. Tea-colored ascites is typically seen in pancreatic ascites. This is due to the action of pancreatic enzymes on the acidic fluid red cells. Cloudy ascites. The total count is more than 5,000. Purulent ascites, the total count is more than 20,000. The test we do on acidic fluid is total count. If it's more than 250 neutrophils, SBP is said to be present. We can also do leukocyte esterase strips, and this instantly can tell us if there is SBP. Then we do a SARG to determine if it's a low SARG or high SARG by subtracting and not dividing the acidic fluid albumin from the blood albumin. If it's less than 1.1, it's a low SARG ascites, and it's seen in peritoneal carcinomatosis, TB, pancreatic ascites, biliary ascites, nephrotic syndrome, and serositis. But if the SARG is high, it's seen in cirrhosis, alcoholic hepatitis, massive liver metastasis, Budd-Chiari syndrome, fatty liver pregnancy, portal vein thrombosis, myxedema, and cardiac ascites. You get erroneous reports if the patient is on diuretics, if the patient has hypotension, or the blood sample is taken a long while back. Then you check the total protein in the fluid, and if it's more than 2.5 grams, it's high protein ascites, and this is seen in cardiac ascites, Budd-Chiari, and it's also seen in TB. If the total protein is low, less than 1 gram percent, the patient is at very high risk for SBP. If the SARG is more than 1.1, the portal hypertension probability is 95%. Classification of ascitic fluid infection. Spontaneous ascitic fluid infection, secondary bacterial peritonitis, and polymicrobial bacterial ascites. Spontaneous ascitic fluid infection is further classified as SBP, spontaneous bacterial peritonitis, monomicrobial non-neutrocytic bacteriascites, which is MNB, culture negative neutrocytic ascites, which is CNNA, and secondary bacterial peritonitis could be due to gut perforation or non-perforation, like in a perinephric abscess. And then we have the polymicrobial bacteriascites. SBP, by definition, the patient should have positive ascitic fluid culture, usually with a monomicrobial organism. The neutrophils should be more than 250 cells per millimeter cube without intra-abdominal source of infection that requires surgical treatment. MNB is positive ascitic fluid culture for one organism because it is monomicrobial non-neutrocytic bacteriascites. The neutrophils should therefore be less than 250 cells per mm cube. and there is no abdominal source of infection that requires surgical treatment. So the patient could have cells of neutrophils of say 100, 150, but they would be growing a bug, which is a typical organism in the ascitic fluid, and there is no intra-abdominal source of infection that requires surgical treatment. What about CNNA? That is culture negative neutrocytic ascites. So the culture would be negative first requirement. PMN should be high, suggested there is an infection. PMNs are more than 250. There are no antibiotics that have been given, and there's no other explanation for it. Now, this is actually very rare in our setting today, because we have very good culture facility. Secondary bacterial peritonitis, ascitic fluid culture is positive, and it's usually polymicrobial. PMNs will be more than 250 cells per mm cube, and there is an identifiable intra-abdominal surgically treatable source of infection. Example, a gut perforation, perinephric abscess, and the treatment includes surgery apart from just antibiotics. Polymicrobial bacteria ascites, as the term indicates, there should be a growth that is polymicrobial on the ascitic culture, but the PMNs are less than 250. This is due to inadvertent gut perforation with your needle. This has a good prognosis. SBP, CNNA, and MNB occur in the setting of advanced liver disease almost always. This could be CLD, acute hepatic failure, subacute hepatic failure, example, alcoholic hepatitis. The most common bacteria grown are in SBP and MNB are E. coli, Klebsiella, and pneumococci, but it does not grow enterococcus or anaerobes. These are usually, though they are present in large numbers compared to the E. coli in the gut, this usually does not cause the SBP. Treatment of SBP. Cefotaxime, 2 grams IV 8-hourly if the creatinine is less than 3, 2 grams IV 12-hourly if the creatinine is more than 3, plus IV albumin 1.5 grams per kg within 6 hours of the onset, plus another dose of 1 gram per kg albumin at 72 hours. So if we give antibiotic along with IV albumin, and that is supposed to reduce the mortality by less than 10%. Prevention of SBP. First is in a patient with prior SBP, we can give them norfloxacin 400 milligrams a day indefinitely. Secondly, the other drug that we use is rifaximin. That would be 550 milligrams twice a day, or 400 milligrams 3 times a day. Ascitic fluid protein, if it's less than 1.5, we can give them norfloxacin 400 milligrams a day during hospitalization. If there's a gut hemorrhage, you can give ceftriaxone IV daily for 7 days. And for primary prophylaxis, you can give norfloxacin for up to 12 months. Now, the criteria for primary prophylaxis, both of these criteria have to be met. One is ascitic fluid protein should be low, less than 1.5 grams. And 2, child score should be more than or equal to 9 with a bilirubin of more than 3, or the creatinine of more than 1.2, or a sodium of less than 130. TIPS procedure. When is it done for refractory ascites? This is actually a significant breakthrough in the past 2 decades for refractory ascites. The criteria are the age should be less than 65. There should be a caretaker at home to watch for hepatic encephalopathy. EF should be more than 60%. Child's scoring should be less than or equal to 12, and the male score should be less than or equal to 18. No alcoholic hepatitis and no severe past hepatic encephalopathy.